someone might feel physically threatened. For assertiveness, this is this could look like standing up for yourself in a situation or asserting one's rights or opinions or needs in a direct and forthright manner. There's also control seeking behavior. This is to gain control over a situation or other people as a way to manage stress or anxiety. It could also look like a competitiveness. This could be like showing strong desire to win or be the best, especially in stressful situation where one feels challenged or threatened. It could also look like resistance change, and this could happen when one perceive a situation to be threatening or stressful. Heightened baseline sympathetic arousal is commonly observed in autistic people, even in the absence of a clear external stressor. And this may reflect chronic hyperarousal or difficulty down regulating stress responses. We're supposed to be regulating our stress responses biologically and physiologically, but when we're in hyperarousal state, that could be hard to do. Also, in autistic people, we can have overactive sympathetic nervous system responses to our environment, and that could be to sounds, lights, or even social interactions. And those could be linked to sensory hypersensitivities and behavioral rigidity. There's a study that has found blunted or inconsistent modulation of sympathetic output. So that would be like altered skin conductance, impacting our sweat responses, as well as our heart rate reactivity. And that's been reported both when we're resting and when we're physically active. There's also sympathetic nervous system dominance, and that could be associated with higher anxiety, irritability, and externalizing behaviors in autism, particularly in males and people with co-occurring ADHD. Next, we have flight. There is physical withdrawal, moving away from the source of stress or threat, avoiding conflict, and that's choosing not to engage in situations that one perceive as confrontational or stressful, like avoiding an argument or difficult conversations. And as mentioned earlier, procrastination, which I think many of us know what that is. So social withdrawal could look like avoiding, conversations or social interactions, even events that might cause discomfort. There could be distracting behaviors like engaging in activities to divert attention away from the stressor for that individual, or even minimizing risk, choosing paths or decisions that are perceived as safer or less likely to lead to confrontation or stress. A study has found in autism that there's reduced vagal tone. This is indexed by low HRSA, and that's a robust finding among autistic people and is thought to reflect difficulties with emotion regulation and social engagement. A study has also found that there's lower baseline parasympathetic activity, which suggests there's a diminished capacity for flexible physiological regulation in response to changing environments like transitions. There's also blunted parasympathetic withdrawal during stress or any kind of social challenges. And this implies that there's reduced physiological readiness to respond appropriately to demands, which potentially could contribute to avoidance or shutdown responses. And then lastly, there's impaired parasympathetic recovery after stress, which indicates that there can be challenges to return to calm or regulated state, which prolongs physiological stress exposure. Next, we have freeze. And mental stagnation is something that we can observe when there's an inability to think clearly or make decisions during a high stress situation. The mind literally freezes under pressure. And then there's hypervigilance, being in a frozen state of heightened alertness. This could be like someone's constantly scanning the environment for potential threats. For emotional numbness, that could look like feeling detached from emotions or even experiencing a temporary inability to feel anything. And that's a protective response to stress. The freeze response is a parasympathetic dominant defensive state that's characterized by freezing or slowed heart rate, not being able to move, reduced facial expression, and decreased vocalization, which is often mistaken for disinterest or defiance. Autistic people may default to freeze when overwhelmed, particularly in unpredictable or socially demanding environments that activate the threat detection systems. Freeze is not under conscious control and reflects a neurobiological survival mechanism, particularly when fight or flight responses are not feasible and have been chronically activated. And the freeze response may be interpreted by caregivers or educators as noncompliance, laziness, or avoidance, rather than a physiological sign of threat or overload. And lastly, to remember, repeated or chronic freeze responses may contribute to allostatic overload, and that's associated with long term health risks, including chronic pain, immune dysregulation, and mental health disorders. Um, Lastly, we have fawn, which is not a well-studied area in autism, but more so in neurotypical and non-autistic people. And I just wanted to have it here to let you know that this is another stress response that might be observed in autistic people, but I won't go into fawn now due to a time limit. Okay, let's talk about how stress impacts physical health. Stress manifests not just in the mind, but profoundly in the body. Sensory sensitivities can transform a bustling classroom or flickering light into an overwhelming experience, triggering a cascade of stress responses that tax the heart and tighten the muscles. There's also gastrointestinal distress, which notably is prevalent among autistic people. It can be intensified by stress, causing discomfort and other health concerns. The immune system, too, may respond erratically as stress disrupts its balance and then leads to increased susceptibility to illness. And sleep, which is very often a problem for autistic people, stress aggravates this challenge and it disrupts the potential for rest and then recovery. And then the endocrine system, which is important for metabolic process, can be thrown into disarray during stress, which affects hunger cues and weight management. And the physical health of autistic people is intrinsically linked to their stress level. I'm running out of time, so I don't have enough to talk about how stress can impact mental health. But if you want to know more, I'm happy to talk with you after the presentation and leave you with some references that I use for this presentation today. Hold on. There we go. And now I'm going to pass it over to Dr. Holing to do her poll.
Thank you so much, Dr. Fan. I really appreciate it. Hi, everyone. It's a pleasure to be here. My name is Calliope Holing, and I'm going to be talking about GI or gastrointestinal symptoms in autistic people. So let's jump into this poll. First of all, how can GI symptoms affect family life? And you can select more than one option here. Option A, they can affect parent mental health. B, they can impact family outings and activities. C, they typically improve household well-being. Or D, they can create financial strain. So take a second to answer that. And then our second question is, what is the limitation of using general population GI questionnaires in NDD populations? A, they're more expensive. B, they're written in multiple languages. C, they may not be valid for people with interoceptive or communication differences. And D, they are too short. So go ahead and take a moment and answer that question, and then we'll go over the answers together. All right, so you should see the correct answers popping up on your screen. So for answer A, options A, B, and D were correct. They can affect parental mental health, as well as impacting family outings and activities and creating financial strain for the family. We'll talk a little bit more about that in the presentation. They typically don't improve household well-being. On the contrary, we find that GI symptoms can actually be a major stressor for the overall household and the temperament of the household. And then for question two, a limitation of using general population GI questionnaires is they're not typically designed for individuals with NDD. And this is a problem because individuals with NDD, particularly autistic individuals, may have communication differences or impairments in interoception, which is the ability to sort of identify and name physical sensations in the body. And so, as a result of that, the GI questionnaires that are designed for the general population don't do a good job of capturing GI symptoms in the autistic population. So, we'll get into a little bit more of those details during the talk. All right. So I'm going to begin by just giving a little bit of context for this, which is health of individuals with NDD is often very complex. We know this population has a greater use of health services, more emergency department visits, more inpatient hospitalizations, higher health costs in general. But despite these greater use of health services, this population tends to have more unmet health needs and a lower quality of care. And I really see this as an equity issue because, as you may all appreciate, health is something that affects everything. It's going to affect your ability to go to school, to perform well at work, to engage in social activities. And when individuals with NDDs don't have the same opportunities to experience good health, that disproportionately disenfranchises them and limits their opportunities for participation. So that is the context for this talk. Next slide, please. Okay, so GI symptoms are quite common in neurodevelopmental conditions. This is I'll go over the figure on the right in just a moment, but the estimates that you see on the left are from a literature review that we published in 2018. And we found that nearly half of individuals with autism in studies published between 1980 and 2017 had at least one GI symptom. What we see from the literature more broadly is that individuals with NDDs, including autism, have around 4 times, or perhaps even more, the likelihood of having GI symptoms compared to the general population. And a lot of different symptoms are common, but most often we see things like constipation, diarrhea, encopresis, which is stool which can leak around an impacted stool or a constipated stool, leading to soilage and incontinence. We also see abdominal pain and reflux. And then on the right is just a visual depiction of that greater prevalence of GI symptoms. You see, while there's heterogeneity across those effect estimates in the different studies, on average, we see a greater odds of GI symptoms in autistic individuals. Next slide, please. All right. So, correlates of GI symptoms and pathology. What I mean by this is that having GI symptoms is not just problematic because of the GI symptoms themselves, but because of the consequences that can result from these symptoms. So, we often see things like food intolerances, toileting difficulties, sleep challenges as a result of GI pain, dysregulated behavior. This can be things like anxiety, irritability, aggressive behavior, even epilepsy, in particular, if someone has an impacted stool, that can actually lead to the onset of seizures or exacerbation of seizures, and then greater emergency department use. And all of these things are, of course, incredibly burdensome and can really drastically reduce the quality of life for an individual as well as their family. Next slide, please. So this is alluding to that first question in our sort of poll. What are the types of GI, what are the types of impacts that GI symptoms can have? The first is on the quality of life of the individual themselves. Things like unpredictability due to not knowing when one is going to have, a bowel movement, for example, or a sort of crisis of GI pain, or vomiting episodes. The symptoms can, of course, be very painful, can limit social outings and activities, can influence the diet, and can even impact employment and schooling. And these also impact the family in terms of the overall household well-being, the parents' mental health, the ability of the families to go out, and the financial health of the families. So a lot of impacts that these symptoms can have. Next slide, please. This is a quote from one of our papers in which we interviewed autistic children and autistic adults, as well as parents of autistic children and adults about GI symptoms. And this parent noted that when the stomach of, his daughter hurts, there's an almost immediate physical reaction. She could scream, she could throw things, and after she calms down, then she tells us, "My tummy hurts." Every time the police had to come out because she was being really destructive, first thing she would say as she regained her composure was, "My tummy hurts." And I share that because it's, I think, a very sad and powerful example of how disabling these symptoms can be, how painful they can be to the point that behavior can become so dysregulated that the police had to be called out in this instant because of the aggressive behavior. It also alludes to the fact that the parent at first had difficulty identifying what the issue was. It was only when the child calmed down and was able to say, "My tummy hurts," that they realized, oh, this is what was going on. Before that, really the only indicator that they had was this behavioral crisis. Next slide, please. Thank you. And this one is from an autistic adult. This adult shared with us, "I don't know if I'll be able to hold down a full-time job or not. Will I ever be able to date or do anything?" And this adult wasn't talking about limitations due to their autism or something besides the GI symptoms. They were literally talking about not being sure if they'd work or date because of their GI symptoms specifically. So again, this can be the degree to which these symptoms can be disabling. Next slide, please. All right. I also want to mention the fact that healthcare can often be a compounding issue for this population in terms of general healthcare, but including GI healthcare. So we often see a shortage of trained and confident providers. So even in providers that may have the training, if they are not comfortable interacting with this population, they're not going to feel confident treating them, and that can lead to a scarcity in providers. The approach to treating GI symptoms in this population is not always clear, and there's an important need for guidelines and more research in this area. There can be communication challenges between the patient and the clinician, diagnostic overshadowing, in which the GI symptoms are misattributed to simply having autism. And then lastly, healthcare settings are not always conducive to autistic individuals. One of the reasons is the sensory environment. This is something I think many of us can relate to. It's loud, there are harsh lights, it's busy, and it can be hard to get someone to come to an appointment. This quote at the bottom is from another one of our qualitative studies, and this parent shared, "A lot of physicians seem uninterested. It's sort of like your child has autism, this goes with it." So again, this is speaking to that diagnostic overshadowing, the fact that often people didn't feel like they were taken seriously because their GI symptoms were just attributed to their autism. Next slide, please. So, what are the potential mechanisms that are driving these GI symptoms? The first couple that I want to point to are some of the more intuitive ones. So, we know that diet tends to be different in autistic individuals because of sensory preferences, as well as some other reasons. And you can imagine that if someone is only eating a restricted diet that is perhaps low in fiber, um, then that individual is going to have more GI issues as a result of that limited diet. We also know that co-occurring issues are, of course, very common in autism, things like anxiety or seizures or ADHD. And GI symptoms as a result of those conditions or as a result of the medications taken for those conditions can also be a driver of GI issues. So this is, for the epidemiologists in the audience, this is sort of just a dag to remind ourselves of what are some of the important drivers to consider. Next slide, please. There are also some other biological factors at play, and I don't have time to get into all of these in today's talk, but I just want to mention them. Things like the gut-brain axis dysfunction, dysmotility in the GI tract, alterations in the immunologic system, the gut microbiome, which has been implicated. And together, this really points to a need for etiologic research to better understand what is driving these GI symptoms. Next slide, please. As I mentioned, GI assessment can often be challenging. In our work, we found a wide range of GI symptom estimates. This is not only due to the phenotypic heterogeneity in autism, but we found it's also due to these measurement challenges. So, for example, in our review study, we saw that the estimate for diarrhea ranged from 2% to 75%. You may look at that and think, well, that's practically meaningless. What can that possibly tell us? And the reason for that, which we found empirically, is that the approach to measuring these symptoms is intuitively significantly associated with the actual symptom estimate. And this is a problem because, as we mentioned in the poll, general population questionnaires are often not valid because of differences in interoception, in communication and language, and in often the presence of intellectual disability. The ways that we assess for GI symptoms in the general population simply don't work in the autistic population, or at least a subset of the autistic population. Next slide, please. So we have undergone a number of efforts to try to improve GI assessment for this population, and I won't sort of belabor this point, but this is one of the publications from our group in which we designed a parent report GI questionnaire, which uses a number of behavioral items which could be indicative of GI distress in autistic children who otherwise have difficulty sort of self-reporting when they're having GI symptoms. Next slide, please. And then lastly, I just want to close by mentioning a study that was funded by AIRP as well as the Autism Science Foundation. This was a mixed method study in which we spoke to autistic adults as well as their parents about their experiences with GI symptoms. And we used those interviews in order to come up with areas of recommendation on how to improve the GI health of this population. Then we administered a survey to a large number of individuals in Spark, and we asked for feedback on those recommendations and asked folks to prioritize those recommendations. And these are the top ones that came out. So we look forward to sharing more about this in a future talk, but I'm happy to answer questions about it in the chat. And I think that was my last slide. I just want to thank the participants, collaborators, and funders, and thank you all for your attention today. Okay, and now I have the pleasure of introducing Dr. Alice Kuo, our fearless leader of AIRP. Dr. Kuo, please take it away.
Yes, thank you so much for having me, and I'm very honored to be part of this answer panel. I was asked to speak about the use of these GLP-1 agonists to manage weight in people with IDD. So let's start with a couple of quiz questions. Number one, true or false, there is an extensive published research literature on the use of GLP-1 medications in youth with autism or other developmental disabilities. And number two, what is one reason to consider a lower or slower titration schedule for GLP-1 agonists in youth with IDD? Your choices are A, to save money, B, to avoid rapid weight loss, C, to reduce the risk of side effects or feeding disruptions in a sensitive population, or D, because children can't tolerate injections. So we'll give you a few seconds to think. Yes, and it looks like people are on the right track. Um, oh, how does this work, Emery? The real answer is going to pop up in a few minutes. Oh,
Exactly. I'll give them about like 20 more seconds and then I'll go ahead and show the real answers.
okay. Yeah, 20 people have responded to the survey and we have 32 people, so just giving a few more minutes or a few more seconds for anybody who wants to respond. Okay, so the answer is available in the poll right now. So most of you got the answer correct for one. The answer is false. There is no study actually published looking at these newer weight loss or weight management medications in people with IDD. And number two, the reason to consider a slower or lower titration schedule is C, to reduce the risk of side effects in a sensitive population. All right, so jumping right in. And I wanted to give a shout out to the Healthy Weight Research Network for Autism. They held their annual meeting in the spring, and these slides were presented by one of our colleagues, Dr. Viti Doshi, here at UCLA, who has a particular interest in autism and obesity, the intersection. And so this is one of my patients actually that I had the pleasure of taking care of over the last 5 years, and he served to be a good example of the use of GLP-1s. And so he is now 12 years old, autistic male with ADHD, anxiety, and an expressive language disorder. And his body mass index was over the 99th percentile for pediatrics. He did gain 30 pounds during the pandemic, which was probably the beginning of his main weight gain. And he struggled socially because of arguments with his teammates, and he started being excluded from hockey, soccer, and other sports. He started sixth grade middle school this past fall with an IEP in place. And he was being bullied and was having some physical, he was also retaliating with some physical aggression. And for his ADHD and anxiety, he was on Vyvanse, Ritalin, and sertraline. Next slide, please. So this is his growth chart from his medical records. And so you can see around the time that he was 7 or 8, the kind of trajectory right here. I don't know if I'm not sharing screen, but you can see the trajectory where he kind of got off of the growth chart. His weight gain was so significant that he is above the 99th percentile. Next slide, please. And so when we think about obesity in the population, we see that in individuals with intellectual and developmental disabilities, the prevalence of obesity is higher. So in the general population for women, it's about a quarter of the population meeting the definition of obesity. In women with IDD, it's up to almost 40%, and it's slightly higher for men in the general population, 23%. And then in men with IDD is 28%. Um, and so adjusting for multiple confounders, the odds ratio is 1.89 times greater for obesity prevalence in children with IDD as opposed to without. Next slide, please. So I'm sure many of you have heard the commercials or the ads on the TV or radio. My 13-year-old son can sing the Ozempic jingle. And so they're pretty prevalent and people are learning about these medications. And over the last couple of years, since they've been FDA approved for weight loss, more and more patients in the general population are on these medications. So it is not surprising that either autistic patients or parents of autistic children are coming in asking about these. And so I think it's important to know that these medications are available. And to understand how they work. So GLP stands for glucagon-like peptide. So glucagon-like peptide 1 is a hormone that your small intestine makes, and it triggers insulin release from the pancreas. It blocks glucagon secretion, it slows your stomach emptying, and increases how full you feel after eating. So keep in mind, it basically slows down your digestive system. And these medications mimic this hormone. So by taking this medication, it also slows down your digestive system. Next slide, please. The thing about the GLP-1s, they are found to have impact on 8 different organ systems in your body. And I will say that when you talk to patients who are on these medications, the thing that really helps with the weight loss, in addition to the slowing down of your digestive system, is actually the impact on the brain, which is what they say is like quieting the food chatter. So I think many of us have the experience of feeling a little hungry while you're working, and then all of a sudden your brain kind of goes to, oh, what kind of a snack can I go get? Or maybe it's lunchtime. Where am I going to go eat? In some individuals in which food is a more important part of their thought processes, that food chatter can be almost nonstop. So anytime there's a little bit of stress or discomfort, automatically your brain goes to, how can I get a drink? How can I get, like a boba or a fruit or smoothie or something? And so these distracting thoughts can change our behaviors throughout the day to the point where, we're actively trying to think about our next ability to get a snack or a meal. In addition to all these other mechanisms of action, we are learning that this type of medication can protect the kidney as well as the heart. And so in people with heart failure or kidney failure for a variety of reasons, GLP-1s are being considered. Next slide, please. The side effects are what you would expect from slowing down your digestive system. So nausea, acid reflux, and constipation are actually quite common. Some people endorse diarrhea. That has not been the case that I've seen clinically. Most people, if they're going to have either diarrhea or constipation, will have constipation. And so if you think about slowing down your digestive system, obviously, if you eat too much, you'll get the acid reflux, the burping, and then the constipation comes from your gut being so slowed down that you're not making a bowel movement every single day. Next slide, please. And so the contraindications are any kind of allergy to a GLP-1. If you're pregnant or breastfeeding, you should not be on a GLP-1. And if there is a family history of medullary thyroid cancer or patients with multiple endocrine neoplasia syndrome. So these are hormone related I guess, syndromes or conditions that would make it detrimental to be on a GLP-1. Next slide, please. Names and dosing. So I think many people have heard of Wegovy. This is the semaglutide, which is in Ozempic. So Ozempic is the name for diabetes. Wegovy is the name for weight loss. They're both the exact same medication. Created in Denmark by Novo Nordisk. It's the pharmaceutical company. It's a very small pharmaceutical company. So the first year that Wegovy was on the market, they only made 2 million doses and there were 9 million prescriptions written. So many people had difficulty finding the medication. And then tirzepatide, which is a similar medication made by Eli Lilly here in Chicago. So the brand name is Zepbound. That's the medication for weight loss. The same medication for diabetes is called Mounjaro. And they've made many, many doses. And so now I have had many patients on Zepbound and have not had any difficulty with them getting the medication. Saxenda liraglutide is a newer medication as well, and is it indicated in children as young as 10. However, instead of being a weekly injection, it's a daily injection, and so patients and parents are less likely to choose Saxenda as a weight loss medication. Next slide, please. It's similar to any other shot that you have to give yourself. It's like an EpiPen. And so this is how you give it. Uh, I've had children as young as 12 be able to give it to themselves, so it is completely doable. And, many pediatric clinics will have nurses that can teach the patients how to administer, patients or parents how to administer this. Next slide, please. So special considerations. So during the period of shortage about 2 years ago, there were compounding pharmacies that could make semaglutide injections for patients. That now is not available any longer because there's not a shortage now that Zepbound is available and Novo Nordisk has made more Wegovy. Yes. There are clinical trials right now for oral pills instead of injections. The injections can still be a deterrent for patients interested in using these weight loss medications because of needle phobia or needle sensitivity. And so the clinical trials are supposed to wrap up later this calendar year and launch in 2026. So the pills already exist for, again, diabetes. It's called Rybelsus. Semaglutide in pill form is called Rybelsus. So the same medication does result in weight loss because I've had adult patients with intellectual disabilities with diabetes that I've put on Rybelsus and they've lost weight. And so this helps. As far as holding the medication prior to anesthesia, some anesthesiologists ask to not give the shot that week, just to not have it in the system because it hasn't been well studied because it is newer. And then finally, when it comes to weight loss, there was a concern a couple of years ago that the GLP-1s lost more muscle mass than other forms of weight loss, but newer studies have shown that the amount of muscle mass or lean tissue loss in GLP-1 use of weight loss is the same as other forms of weight loss. So in typical weight loss, 65 to 80% comes from fat tissue and 20 to 35% comes from lean tissue. So it's very important for people on medication for weight loss to engage in some sort of muscle building, strengthening exercise regimen. Next slide, please. And so here we go with our quiz question. No published studies or trials have been done with GLP-1 agonists in patients with IDD. I've spoken to medical science liaisons from both Novo Nordisk and Eli Lilly, pitching the idea of doing an investigator-initiated study in the population of patients with IDD. Obviously, they're not that motivated because these medications are flying off the shelves and they don't really need specialized indications. I'm just going to give it a few more years when things kind of settle down and there's more interest. I do think that we can get studies funded either by the pharmaceutical companies or other research means to look specifically at GLP-1s in our population. Multiple case studies have noted an improvement in eating disorders and a decrease in aggressive behaviors. They're also looking at the use of these medications in addiction and substance use disorders. And so there is that CNS effect that I was talking about, the decrease in the food chatter must lead to maybe decreasing the compulsive food behaviors or other things along those lines. Again, these are case studies of unique patients. I've had a couple that have told me that they have cut down on their alcohol or nicotine use, not intentionally, but being on these medications just stops the cravings. And so I do think that there are more uses for GLP-1 than we currently know about. So more studies need to be done. Next slide, please. I look at GLP-1s as a tool in the toolbox. And next slide, please. It goes together with lifestyle approaches. So the thing that we know is these GLP-1 medications only last about a year or two. So patients will initially lose weight and they'll feel great. But if they don't change their eating behaviors or change their approaches to lifestyle management, at the end of 1 to 2 years, when the medication no longer is as effective, the weight will come back. So the recidivism rate or the rebound rate of weight gain after GLP-1s, either stopping them or after 2 years, is 80%. And so to me, I explain to patients, this is your chance to have something help you with your lifestyle change. You still have to make the lifestyle change. Otherwise, if you stop these medications, the weight will just come back. Next slide, please. So I tend to start low. If weight loss is accomplished with a starter dose of 0.25 milligrams weekly, I'll stay there. If we go up to 0.5 and there's side effects, we go back down to 0.25. Sometimes the goal is to plateau or not gain weight as opposed to losing weight, especially in children, because they will get taller. And if they still get taller, but they don't gain weight, they will then actually get thinner. Monitor closely for side effects, monitor closely for food intake. I haven't had patients stop eating altogether, but I've had colleagues tell me that they've had patients who are not hungry at all, that they just don't eat. And so we definitely don't want that. So it's, manageable and telling patients they still need to eat, but again, in a healthy way. Next slide, please. So just to follow up on my patient, this was him back in November. And, he was on stimulant medication, but that didn't really curb his appetite. It did make him better on some of his classes. Next slide, please. So mom brought it up at the end of that visit because grandma was on it for her diabetes. So at 12 years, my patient was 5'2", 185 pounds, and his BMI was 33. I went ahead and prescribed it at that visit, but insurance authorization took a couple months, and they were finally able to obtain the medication in January of this year, 2025. We started with Wegovy 0.25 milligrams weekly for 4 weeks, which is the starter dose, and then increased to 0.5 milligrams. And then he came back to see me 6 weeks after he started the medication. Well, so let's see, what was I going to say? There was a point I was going to make about this. Next slide, please. Oh, because his BMI was 33, I anticipated he needed to go to the 0.5 milligrams. FDA approval is for anybody with a BMI of 27 or higher. So your insurance should cover it, but different insurance plans will make you pay different amounts. So they may cover it, but maybe only half the cost or whatever. The good news is over the past year, the cost of both Wegovy and Zepbound has come down. So it used to be $1,600 a month, and now it's down to about $400 a month. And so here is my follow-up visit with my patient. And for the last 2 weeks, he developed some vomiting for 2 days after injecting 0.5. And he was able to have almost like an 18-pound weight loss in 6 weeks. So you see there that when I saw him on November 1st, his weight was 185. When I saw him on February 21st, his weight was 167. And so in addition to addressing his ADHD issues and, him starting middle school, he had a great second semester. So he was now doing homework and turning it in. He was socializing. He was playing D&D with a friend, going to the local comic book store with them. And then also, because mom gave him a chore, he had to walk the dog 30 minutes a few times a week. And he had not participated in PE in elementary school, but now was participating 3 times a week. Next slide, please. So together with mom, we decided to go back to the starter dose 0.25 because he did lose weight on it, and then he wouldn't have any vomiting, hopefully. He has lots of wins now at school and in life, and I say that a lot of my patients, my autistic patients, they just need a few wins to get them back on track. Having at least one friend, a better experience at school, a better experience at home. And so after 4.5 years of struggles, it's a lot around mental health, this was very successful. Next slide, please. So these are a few thoughts. I know we're almost out of time. Management of side effects. If they continue to eat on these medications, then they will have the acid reflux and the vomiting because your digestive system is slowed down. Optimizing protein intake and having muscle strengthening exercise is important. Adult studies suggest that weight loss plateaus after a year to two. Not enough kids have been on it, so we don't know what it is on kids, whether they're going to plateau or not. Decreasing cravings, as I mentioned, and the rebound effect is there. So the ultimate goal is not to be on this medication long term. Next slide. I think that might be the last one. Oh, yes. All right. Ended right on time. I'm so sorry. But happy to stick around for any questions if people have any.
Yeah, thank you, Dr. Cole. And we will have opportunities for people to engage with us. We have some email contacts here on this slide. We'll also pop it into the chat so you can save it or copy it, hopefully. I don't know if that's going to work. But please record it and reach out to any of us, Heather Brown, Emily Hotez, and myself, Jenny Fan, if you have any further questions and want to engage. There is a question for you, Dr. Cole, in the chat. For anyone who have to go, please hop off. And thank you so much for joining us today. We will be in touch if you've registered. But if you can stick around a little bit longer, we can answer questions. I'm reading your